My name is Haladura. I'm an independent patient family engagement consultant, originally based here in the DMV. For those of you not from the DMV, that means DC, Maryland, Virginia. I just relocated to Southern California about a year ago. I initially came to this work about 12 years ago because of my own personal journey with my oldest daughter, who's a 2-time liver transplant and a bone marrow transplant recipient. So when Sarah talks about some of those bumps, yeah, we've experienced some of those bumps. But we've also experienced some amazing things during our journey. And certainly, I've really wanted to contribute that lived experience in my work. And I'm excited today to talk more about some of the tools and strategies that we can really utilize to create this person-first health system, community-first health system. And the future of healthcare design and healthcare transformation, I think, really involves partnering with individuals, caregivers, families, and communities to envision what this person-first health system will look like. And certainly partnering with policymakers and various organizations across the spectrum to really co-design will be of the utmost importance as we continue to vision what the future may look like. So I'm really excited to have my fellow panelists this morning who are going to take us on a journey, no pun intended, around patient journey mapping and really fitting into our theme about a patient-first health system. The map you see in front of you this morning is something I was introduced to very early on in my own work. And I remember being so struck by it. And at the time, no one really called it a patient journey map. It was just a mom saying, here's how our life looks like, taking care of my child with complex medical and health needs. And I remember saying to myself, oh my goodness, if I had to draw this out, what would it look like? How does it make me feel? How does it demonstrate how I interact with the health system, with my education system, with my community? And I'm so excited to introduce Stacy Chang, who's a designer and advisor of complex health systems, Elliot Fishman, who's the director of policy and the programs group at the Centers for Medicare and Medicaid Services, and Jen Horangeff, who's the founder and CEO of the Savvy Cooperative. And they're going to take us through today. What does patient journey mapping look like? What might it look like? How has it impacted the work that they've been doing, and from the places they're at, where do they see this taking us, this tool, this human-centered design approach to really envision what a patient-first health system may look like? And so I wanted to ground our conversation this morning with our panelists to really just do some level setting around what is patient journey mapping? What does it look like from your perspective? And how do you see it kind of propelling us towards this person-first health system? And I'd love to start off with Stacy to kick us off this morning.
Sure, I'm happy to. It's a pleasure to be here with you all and for this discussion. So I have a couple of illustrations I want to start with, maybe just to ground us in what patient journey mapping potentially can look like. And this is for certain an eye chart for you in the audience. It's really difficult to see, but fortunately it's also published publicly, so I'll give you the reference later. In some ways, patient journey mapping has evolved, like my own career has evolved alongside the utility of patient journey mapping. I was a designer and ran the healthcare practice at a company called IDEO for a long time. And at the time, we used it as a way just to reflect the experience that individuals were having when they engaged with what we call the healthcare system, as a tool of empathy and just to understand their experience and how we engage with them. Over time, over the course of the last 10 or 15 years, it's evolved into a much more useful tool because it begins to reveal gaps in the system that can be filled by new offers, new services, new technologies, and often new policy. And so this illustration is from, I'm a recovering academic. This is an academic publication. This is in the Journal of the American Heart Association. And it is one of several maps, and this is just the overview map, of the experience that children and their parents have when a child is born with congenital heart disease. And you can go through the different stages: prenatal, when there's a discovery or diagnostic that may be the case; interstage, when they're born, and through the multiple surgeries necessary to actually establish hopefully a viable life going forward, and then much further on. And I think what's really important in journey maps like this is it not just explains the things that individuals will experience, which is setting expectations for a family who's going to have a lifelong journey with this disease or this condition, but also the choices that they will have to make. And I think it probably doesn't need to be said in an audience like this, but I'm going to say it anyway just so that we anchor, is that we want individuals, humans, people, the people we often call patients, to have an active role in their own care, in their own decisions, right? And part of the tools that we're going to talk about here is about giving them options, knowledge, and choices about what they will do in that lifelong journey. So if you dig into this, I'll show you the next one. This is an even more inscrutable from your point of view right now map that digs into just the interstage part, the part where there's a heavy medical intervention, often surgery, and a lot of choices that have to be made. And what you can't see down the left side are we call these swim lanes. There's several swim lanes, and they include things like what you're feeling, what you're doing, what you're thinking. And that's very empathetic towards the experience of the individual and the family who serve as the patient surrogate for a lot of that time until they become their own advocate. But it also tells you, as a system, what are we designing to support the state that they're in? If they're feeling particularly overwhelmed, what are we designing to help them through that? If they find it difficult to do something that we're asking them to do, what are the tools we're creating for them? And often, as they make these transitions, there's big gaps where their mood and their ability to make change or to act on their own behalf dips. And those are almost always the illustrations of where there are gaps in the systemic ability to transition them from one place to the next. Oftentimes that's policy oriented. So as an orientation, I wanted to share those first, just so we sort of have a common illustration or something to reference, and then I'll pause there.
Elliot?
So, thank you, Stacy. I actually want to pick up where Stacy was just walking us through. So I work at the Innovation Center at CMS. The Innovation Center, formerly the Center for Medicare and Medicaid Innovation, was created in the Affordable Care Act. I would say we're still almost a startup, right? So we really began operations a little over 10 years ago. In government terms, I think that counts. And we are in the business of designing and testing and evaluating models that change the way generally Medicare or Medicaid benefits are delivered. That includes changing the actual benefits, changing the way we pay for existing benefits, changing the way we're trying to organize the providers and the delivery of those benefits. And it's really easy to lose the thread of what the patient's experience is of those programs from here in Washington, D.C. or from Woodlawn, Maryland. And the first way in which we try to think about the patient journey is exactly what Stacy was just describing in the design of the model and in thinking about the experience of that design from a patient perspective. We also have to think about it, and it is part of our legal mandate and a big part of how we operate in terms of how we're measuring the change, right? So trying to quantify and measure and demonstrate how the patient experience has changed. And in fact, not only measure that within our model, but measure it in some sort of a comparison group. Right? So we need to be able to measure the patient experience for people who aren't participating in our models, who may not be engaged in the same way. That's an incredibly important challenge for us that we're right in the middle of trying to figure out. Say the third way, and here I'm going to show a slide, that we try to think about journey mapping is about how we communicate our models. A lot of our models are voluntary for either for providers or for the patients themselves. And here's a real break from the kind of design document that Stacy was just showing, right? This is very recent, and this reflects an effort to communicate a kind of before and after for a new model. This is a model that centers on adding a community benefit for people and for their caregivers, people who have dementia, in the Medicare program, right? And the Medicare program generally does not cover community benefits related to mild and moderate dementia, and a lot of people end up going into a custodial nursing home residency and spending down and qualifying for Medicaid. So I think this is an incredible opportunity to deliver something that will change the patient journey of dementia, and that's what we're trying to capture here. But you'll just see how when we are communicating, we're trying to make this very legible and really speak to literally the word journey, right? Speaking to a pathway in a very direct way. And I would add in parentheses, one more sense in which we're trying to think about a journey, and this isn't the patient journey, but I would say it's the provider experience, the moral experience of providers in care. And I say that in parentheses because it's not our main topic today, but part of what we're trying to change when we talk about changing the way we finance healthcare is not only the patient experience, but making healthcare payment a much more respectful and professional experience for providers who are some of the most highly trained professionals in this country. And yet, I think the existing volume-based way in which we incentivize providers doesn't recognize that. And I think that's ultimately, I would say, a important, if secondary, consideration in terms of trying to think about the patient experience too.
Thanks, Elliot. Jen?
Thank you. So I run an organization called Savvy Cooperative, and what we do at Savvy is we're kind of like a marketplace for patient insights. So I spend my days working with companies or innovators, connecting them with the right patients with different conditions, with different criteria, so that they can actually talk to the people they're trying to design for. So I love that we outline these different types of journey maps in congestive heart failure or in dementia. And I just want to make sure that we're clear that when we do these journey maps, we are designing them based on the fact that we have actually talked to the patients and caregivers who've experienced these things. Just to call that out, that yes, we can all have our hypotheses about what that is, but until you have those lived experiences, you don't truly know. And that's what we're trying to talk about. Stacey talked about like those gaps where there's not enough support. We need to understand what those things are. And if we want to create a more inclusive way of understanding that, we also need to make sure that when we do the work, we're talking to a representative population so that we can understand the differences. So making sure that we're including historically excluded communities to be part of these conversations. Pediatrics or caregivers or things like this that, maybe we're like, oh, kids, they can't tell us about things. Yes, they can. And so just always being really clear. We know that they can tell us a lot. So being clear about how we're collecting this kind of information. And I spend my days working across the healthcare ecosystem, and this can happen in a lot of different places. So that can be, thinking about what is the experience like when you're getting diagnosed? How are you making treatment decisions? How are you picking them? How do you have to make a new decision? Sometimes when I like to give kind of like workshop type talks, what I'll do is I'll ask the audience, usually a bunch of industry people, and I do a lot in like life sciences, and I'll say, let's make a map of what it's like to pick up a prescription, to get your prescription. And a lot of the time, they break off into groups and they go through and they talk to me about like what's a phase 1 clinical trial, phase 2, phase 3, they've got their bench research. That's where their brain is anchored to. But if you talk to a patient or a caregiver, they're like, oh my gosh, I have to find time during the day to go pick up my medications. I get there and I find that it's not covered by insurance, and then I have to call my doctor, but they're closed for the day, so I have to wait, and it's this whole rigmarole. Or I don't have, transportation to get there. All of these different things impact somebody's ability to follow a treatment plan. One of the worst things that I hate when we use the term non-compliant in healthcare because it sounds like it's putting the onus on the patient as if they don't want to be well. Oh, they're not following their treatment plan. But if we look at these patient journey maps, we see there are all these barriers. It is so hard to follow a treatment plan. I have been a patient since I was 11 months old. I have chronic illnesses. I had a brain tumor. I do this professionally. And I still bang my head against the wall trying to get records here or make appointments there. So just because you even have the knowledge doesn't mean that our system is designed in this way. So the more we can do this work to actually kind of level set what are those different experiences, and again, from the patient perspective, so that we can invest our time and resources in the areas that are going to be the most meaningful changes for patients and families, I think is the most important.
Thanks, Jen. And you all touched upon kind of the depth and breadth of what patient journey mapping is and what it could look like. And I want to get a little bit deeper into that conversation around, when we're looking at this as a tool, as a design process, as Jen said, you could be looking at the patient experience just to get a prescription right. Or you could be even broader when you're looking at population level or groups such as those living with dementia and their caregivers. And so I would love to kind of talk a little bit more about those tensions between when we utilize patient journey mapping and your experience. How can we create, if we're looking at that individual, to something broader at a more population level? Or do you think this should really be very specific to individuals? I'd love to kind of hear your comments about it, and I'll start with Jen this time.
Yeah, I think that, it's nice to get sort of a broader spectrum, but oftentimes what we see is that there might be sort of different personas that get broken out, that you can sort of see, one example can be how they say some patients are more like activated, more engaged in their health, and then there might be those that really just want a clinician to tell them what to do. Just two simple examples of that. So then you can start to understand maybe what those different types of patients or families would experience. But I think it's important to have some heuristic, some place to anchor into it. But then, of course, you, as Holly, you were saying that you mapped out, what your family experience is. It's important to know what that is, because obviously each system is going to behave a little bit differently. I mean, each health system. So when you go in, the front desk is going to be in a different place. So you need to just kind of figure out some of those individual aspects as well. So there is utility in having something to help level set, especially for policymakers, innovators, to just kind of get a high level view. But that's why we always need to do the deep work to understand what those individual experiences are.
Thanks. Elliot?
So I can't tell you, Jen, how much I agree with both your first statement and the second one. It is extremely difficult in a big federal agency to access patients in the way that you're describing. I think we can require or try to require providers who we work with to do that, but I just wanted to share one experience to underline what you're saying. I worked at a big provider system in New York City early in my career at a time when the buzzword in the world of health policy was really palliative care and end-of-life care. So those of you who have been in the field for a couple of decades will remember the moment that palliative care and end-of-life care had in like the mid-2000s. And you can't imagine a more principled, idealistic objective in health policy than that. But when we engaged, and this was part of my function at that time in the health system, when we actually engaged with patients from all different walks of life, and this was in a kind of low-income to middle-income part of New York City, what we found is that there was a great deal of, I think, really important and legitimate concern about healthcare providers denying necessary life-extending care for business reasons, right? And it was initially we'd hear that and be like kind of defensive about it, and don't people know what's good for them, and we're trying to do the right thing. And then over the course of that experience, it really informed how you know, how I try to correct for the ideology and the buzzwords that we have today in healthcare policy. I just grew more and more sympathetic to that perspective the more we engaged with those people who were actually on their journey and interacting with the health system. So as challenging as it can be to access those voices and the diversity of those voices, I just think it's a critical operational step in program design. I'll say, as somebody who worked at a consumer advocacy organization for many years, there's a difference between talking to representatives and talking to patients and talking to consumers, and that's a really important push to find a way to actually be informed by those direct voices of the people who are experiencing that care.
Stacy?
Yeah, I'm going to respond to your question on both fronts. One is how much a gift a journey map is to a patient in terms of empowering them to understand what to expect, the choices they have to make, and all of that. Jen made a great point. Nobody wants to get better more than the patient does, right? And giving them, we've all experienced the healthcare system. How many times have you walked out there going like, I have no idea how this is going to play out for me? Everything from like, a blemish on my skin to like, a broken bone, right? Like, what's the chance you have a clear idea of the journey you're going to experience, the choices you're going to have to make, the knowledge you have to make those choices, on and on and on. So it's incredibly valuable. It is a gift if we do it well. But more than being a human-centered designer, now in my current guise, I find myself doing more systems level work more than anything else. And these are really complex systems. And in systems theory, you talk a lot about where we have leverage on the system, right? We have leverage at the individual level, enabling a patient to be their own advocate. That's its own leverage. Changing what we measure, measuring engagement and success in engagement, if we can turn that into something that has actual real financial teeth to it, which is a role you have leverage on, right? Also shifts the behavior of the system, changing policy. And it's important to consider what these maps tell us about where our leverage is. There's a piece of work that I was doing a few years ago in Central Texas. We're redesigning the public mental health system. And the legislators started by saying, hey, we need to rebuild literally what was the insane asylum built 100 years ago, right? And I use that terminology intentionally because that was what it was. And they're like, we need to increase the capacity of that bed. I was like, increasing capacity for an institution that receives people after they've suffered through everything else is actually not the modern solution to our mental health crisis. In fact, if you start mapping the journey of individuals through the system, people who decompensate and end up being institutionalized, and I'm using all these terms intentionally, right? They usually enter in two different ways. One is they show up at an emergency room hoping that there's somebody in the ER who knows what a mental health crisis looks like differently than a physical health crisis. The other more common scenario is they end up in the back of a cop car because they've done something as a consequence. And then they end up in a very different journey through the criminal justice system and competency restoration. The terminology is appalling, right? And they almost never make it out of that. Right, and what you is for them to leave, is to exit the criminal justice system and find care in a much more, frankly, caring scenario. And it's all about policy. Our ability to get people out of a revolving door that actually never lets them go. And so when we look at these journey maps, they have obviously incredible utility for the individual they're affecting. But from a system level, they start to reveal places that we can create incentives for providers to act and health systems to act differently, policy, new technologies. I think we really do have to view these maps as revealing of opportunities to intervene on the system itself.
And that's a great segue for my next question. I always visualize things as the big P and the little p. Big P policy is at the federal level, and then obviously we go into state and local. For me, I typically am working in the little p level, which is really not giving one is more powerful or more important than the other. work in conjunction with each other, but I'm working at the systems level, the health system level, partnering with organizations such as CMS and others to really look at how do we engage people, communities, caregivers to really not only understand experience, but how we can partner together to work on some of the solutions you all alluded to. And I'm just wondering, where do you see in your own work that patient journey mapping influencing whether it's the big P or the little p or both? And I'd love to kind of hear your thoughts about that. And Stacey, I'd love to start with you.
Yeah, I mean, in some ways, I've touched on that a bit in the last response. And one of the things that I want to be really clear about is any of these patient journey maps are stale as soon as you publish them, right? Because they are a capture in time of what the experience feels like in the systemic circumstances in which we exist, right? So as soon as you introduce an incentive to payers or to providers, or you change policy, those journey maps change in response to that. And it should be a continuous effort to continually update, because then you get to see the impact that your provocations into the system create for the experience of the individuals. Any rule changes you make in reimbursement should have a market effect. And if they're not, it should be a feedback mechanism for how you change those sort of things. And so I think we should not view them as beautiful wall art, right? And go, oh, isn't it interesting? That's what people experience. But really as a provocation to how do we change that wall art to make it a more beautiful journey. Anyway, hopefully that's a useful input.
Thanks. Elliot?
So I think as a representative of Big P here, that one way to think about it is that what we're trying to do is with the big levers of federal payment policy and provider regulation is to stop getting in the way or moving in the wrong direction around the small p health system incentives, and creating more space for and creating better incentives for health systems to engage with patients on that journey. I'll say it's very difficult. And part of the reason that it's very difficult is as much, and this is part of the reason I referenced when I started about the moral experience of providers. It's not that I feel like that is its own independent goal as separate from the experience of patients, but the organized interests of providers around Big P, I think is often driven by a real attachment to the status quo in terms of payment in ways that can betray the moral interest of providers in getting to more patient-centered, more equitable, more just delivery. And we need to keep coming back not just to the journey that patients are on, but how that interacts with providers to kind of get past the organized business interests of providers to be able to center the experience of both the recipient of that care and the provider of that care.
Can I interject for a
Yeah,
second?
sure.
I mean, so amen to that. I mean, the one thing I often say is there's actually two sets of humans in this system, right? There are the people who are needing care, but there are the professionals who took an oath to care for other people, right? They have human needs as well. And in addition to patient journey mapping, we should be mapping the experiences of providers who are often betrayed by the system and the business interests and the medical industrial complex that we have, right? In doing the things that they care most about. And so understanding both of their perspectives, being empathetic to both of them, and then triangulating how you improve both of those together, because they are often in hand in hand trying to achieve the same thing, is critically important. And then shifting the incentives and the regulations and the markers and milestones that we judge the quality of that progression by, I think is critically important. We shouldn't lose sight of that. I know we're talking about a person first, and a person means not just the people who we traditionally call patients, but also the people who are trying to provide that care.
And I think
Huzzah.
building on that, it speaks to the conversation we had last night, Stacey, where I told you a little bit about my background. As a sick kid growing up, many sick kids think that they're going to go on to be physicians. So I was on that track, and I was pre-med. But truthfully, I sort of ran into so many issues in the system that my providers couldn't practice the care that they wanted to because of incentives, because I wasn't allowed to be prescribed the different types of treatments that they wanted to. It made me disenchanted with the entire system. I was like, I don't want to go do that. So that's why I became, the human-centered designer, because I'm like, let's go fix that instead. And so coming back to, the big P, the little p, I might interact more on like the petite p level. Because really, I work with a lot of companies and organizations that are the building blocks of what might go into a system. But the challenge is, until we do have the policy level, everything feels just so disjointed that it's so hard for things to interact in a congruent way that is easy for patients because we're doing it so piecemeal. So there is this sort of whole chicken and egg. People don't want to do things until they're required to. Then when they're required to, there's no actual specific guidance, and then they don't know what they're doing, and they look towards folks like us. How do we piece this together? So that's why it becomes so challenging. But to maybe dig in a little bit more, the types of things that we might be doing journey mapping on are, how does a particular product or service help to mitigate any of those barriers or gaps in that sort of patient journey, and understanding those different ones, so that as we piece them together, what I don't want to have happen is that we keep creating things in silos and then adding more and more burden. And this happened during the pandemic. Everything rolled virtual, and they're like, great, we'll just quickly roll out all this digital stuff and virtual appointments, and we're golden. That is a very privileged position to think that that works. This created so much discordance in how people received their care. People didn't know how to use the tech, didn't have access to the tech, didn't have broadband, all these different types of things. So it's a bunch of people in our ivory towers saying oh yeah, no problem, I can do this, so you're good, right? And so that's why things didn't interact with each other. Patient portals with other apps, with other telehealth, get on your Zoom link, I'll text this to you. And then right now I have a new provider that is using my chart, or it's at my health system that I use all the time, have been for decades. But this new department has their own portal, and so they have a messaging portal. And it wasn't until I ended sort of a treatment cycle that we were doing that then I learned that there was another portal they never told me about that had my treatment. I was like, why don't I know what's going on? So there's 3 portals, one to message the hospital, one to message my providers, and something else. And so it's bananas. And that's what, until we can take care of the petite p and the big P together, it's always just going to be so spotty.
I just want to say thank you all for indulging me and utilizing big P, little p. And now petite p. Thank you, Jen.
You're welcome.
I did want to give some time for the audience to ask questions, so would love to kind of hear your final thoughts about what does the future of patient journey mapping look like, and how could it continue to influence building a person-first health system? And more specifically, and you all have touched about this, I love, Elliot, that you pointed out that provider experience is equally important. And I think, that's where in our work in patient-family engagement, we talk a lot about that co-design process, and I know we'll be digging deeper into that in the next panel discussion this morning. But, what does that look like, Elliot? What does that, co-design process look like, valuing both experiences? And when we talk about payment, who's defining value? We talked about value-based incentives and value-based payment and those things we talk a lot about in our discussions, but we don't really talk about how we define that, and are we defining that, are we co-defining that as groups? And so would love to kind of hear your final thoughts, and last but not least, equity. Equity is something we talk a lot about in our discussions when we talk about a person-first health system. how does that fit into what the future of patient journey mapping look like, and how could it be utilized as a tool to influence quality improvement, equity, and really valuing the experiences of people, of caregivers, of families, but also of providers. So Elliot, I'd love to have you provide your final thoughts there.
Sure. I'm actually going to start with the equity subpart of that question. And for the Innovation Center at CMS, the greatest barrier to our being able to contribute more to healthcare justice in the United States has been which providers are participating or not participating in Innovation Center models. And I would say one of the most important prerequisites, it's not getting us to where you're describing, that we have been working on in the last 2 years, has been a real focused effort to bring providers of care in communities of color into Innovation Center models. And that's, not, like I said, it's a prerequisite, right? That's not going to get us to actual accounting for in speaking with those communities of color in the design of those models. But if you're not even in those communities, there's really not much you're going to be able to do about design. So I would say that we are in the early stages of really being able to build the infrastructure in terms of community engagement and learning how to realistically, again, we're in a big P world, right? So how to realistically design the participation agreements and the quality measurements, like these kind of infrastructure elements that then drive at the point of system design, real communication with patients and with communities that can then lead to a fairer and better experience of care and ultimately better population health outcomes.
Jen?
Well, I'll point out the fact that regardless of whether or not professionals like ourselves are making journey maps, patients are doing it on their own, or family members like yourself, right? And I think that this also does tie into health equity, because there is a lot of distrust in the system, rightfully so. And so that's why people may not necessarily trust what's going on within the system, and they're asking their peers, their friends, their community, people that they do trust. Essentially, they're creating their own journey map. What happened when you got diagnosed? How did you make this decision? You were offered a clinical trial. Nobody's ever spoken to me about that before. So they're having these conversations. And so that's why when we talk about why is it so important to then bring them in to have a multi-stakeholder conversation, because they know so much. And so that's what I think from a health equity standpoint, if we don't do the work to include all of those different voices, then they're going to be creating their own journey maps, because they're saying that the big P isn't accommodating what their needs are. And so that's why we always need to continually go back and forth. And I also want to point out that it is this iterative process. Like Stacey said, these things become outdated. Imagine they get published, how long did it take from when you
A whole year.
made that journey map to when it's in your peer-reviewed journal, right? And so we need to be current with it. And we need to think about this like how product designers design things, right? They run on these sprints, they iterate. And so we need to continue to do this so that as we introduce new things into the system, that we see the effects of it, we ask, we get feedback from patients, from providers, from every different stakeholder, and then continue to iterate to make sure that we are creating the most equitable health system.
Thanks, Jen. Final words,
Sure.
Stacey?
The journey map that Elliot showed, I thought, was really provocative for one primary reason, which is it shows the difference between what people are experiencing now and what we hope they would, right, in an idealized model. And in between that is a lot of gap. Systems like these are non-deterministic. there's no singular authority that says, okay, this is what's going to be, and you deploy it, right? You provoke the system, and stakeholders with different incentives respond differently. And what I hope becomes true of journey maps is that they actually become a measurement and evaluation tool. In the gap between what is and what you want, you can see where things improve and how specific kinds of provocations, whether they're policy around reimbursement or technology interventions, or it doesn't matter, how they close the gap. So you understand how the system behaves in response to certain provocations. I would love for patient journey maps to become the measurement and evaluation tool for what is essentially a marketplace to improve the experience and quality of care.
Thank you all so much for your insights. I did want to leave some time for questions from our audience. So we could probably take a couple questions in these last 10 minutes. If you raise your hand, Alliance staff will come around to you with microphones, and we'll be happy to answer your questions.
Thank you so much for the words, and thank you for the opportunity to ask questions. So my name is Nancy Connolly. I'm an internal medicine primary care doctor, also a new Robert Wood Johnson Fellow. I love the visualization of the journey maps. I've often thought in my role in primary care that if patients, and I want to say people, if people had a community health worker, how would that change the map? I very much like, Stacy, you said, how do we change the map to make it a more beautiful journey? And Jen, how does a product or service change the map? And in the very first image you put up, what if that person, who ideally is not yet a patient, had a community health worker that they could go to first? How would that change it? In pilots I've seen, community health workers are often attached to people who are quote unquote high utilizers. What if we could attach community health workers before people engage with the system? I'm just curious on your thoughts of that, or if you're aware of programs along those lines. Thank you.
I'll weigh in because we do a lot of this work now. Actually, pharma companies are looking at how do they engage in preventive care and thinking about these kinds of things. So we do a lot of work to even say, where is that community health worker coming from? Or this could be, where are educational resources coming from? Because the stakeholder or group or organization that it's tied to, obviously there's a lot of bias that we all have as individuals that can impact that. So we hear things about, depending on where that's being offered, can impact the utilization of it. Like, my insurance company gives me my nurse navigator or whatever, and I remember early on, I'm like, heck no, I don't want you to know how sick I am so you can deny me more insurance later. And so there's different ways that we, think about things. So I think that it matters. People do like the idea of it, but I think it's going to take, where is it coming from for people to really want to adopt?
So I just wanted to, I know we want to get to other questions, but just to quickly note that the Medicare program just put out as a proposal, but hopefully will be finalized to start covering community health workers in Medicare, which is a huge development that a lot of people, including some people in this room, have been involved in for a long time. So that's a step in the direction that you're describing.
Kathleen Sheen with the ALS Association. So we've done a journey map for ALS patients, and I think our hope is that we'll be able to take it to CMS and to insurers in a goal to impact how care is delivered. However, I'm not too hopeful about that because I think that many of the systems are designed around cost containment and things like that. So I appreciate the journey map, and we did develop it with patients, and I agree 100% that family support group and patient support groups are really where the action is in terms of the journey map. But I'm just curious as to what your thoughts are in terms of how do you take the journey map and influence policymakers?
I'll start if I can. That's where the journey map as a living, breathing document and an indicator of how provocations in the system make change becomes really important. And you may not have good examples yet for your specific disease or condition state and how policy, for example, will change that. But there are examples in other places. And so it's still nascent, but there are examples of where a policy change, if tracked on something as tangible as a journey map, shows where that policy shifted the experience and also the cost of care for that individual and outcomes. And I think it's incumbent upon us, those of us who are interested in this space, to build a collective evidence base that we can use as compelling evidence for those appeals to individuals who have the authority to make change, as evidence for change. Until we have hard evidence, and we talked about subjective versus sort of objective things. Subjectively, we know it makes a difference, but objectively, because the medical industrial complex runs on objective evidence, and we have to be able to translate that. That's the critical element in using something that is very feels, right, to something that is very hard numbers and and ledgers.
And if I could just add to talking about building the evidence base with patient journey mapping, we also, I think, too, have to push that lived experience is just as valuable as some of that hardcore data.
Yeah.
That's something I struggle with a lot in my work, that we are not valuing the qualitative as much as the quantitative. And I think what I loved, Stacey, you said a little bit earlier, was actually using it as a measurement tool. And that truly is showing the experience and integrating it into that measurement system so we can improve. And so I think, too, as we talk about policy here today and the big P, understanding how we can integrate that experience to be as valuable as the evidence, so to speak, that it is just as, it is evidence. It is evidence. We just need to start valuing it as evidence and being able to talk to policymakers with that notion of it is evidence and here it is. And I think the patient journey map is a great opportunity to start leveraging that perspective.
One way that we like to sort of frame it is like the big data, that gives you signals. It might tell you that something is wrong, but you need to have that rich contextual data to understand why and how to fix it. So that's really where the two are so complementary. And what we do at Savvy is mixed method research to be able to have, hey, look, here are these things that we can give you your descriptive statistics, but at the same time, it's married with these quotes. So you go, oh my gosh, like I didn't know that was happening. We recently helped a pharma company build their own internal roadmap for where they would get patient insights along the way. But at each juncture, it was captured with like a story of like the hardship that patients had so that you can go, oh, that is why I need to go do that kind of work at that juncture. So I think that it really just helps build that empathy within our system as well.
Let me give one super tangible example. I'll be quick about it. I often say the most underappreciated leverage we have in a health system is the informal caregiver, usually the adult daughter or mother in a family, right? They care for their children. They usually care for both sets of aging parents, and they're usually ones kicking their husband off to do his annual appointment. I'm being stereotypical, but it's not inaccurate. Just to be clear. Whether it's that individual, you, Hala, in this case, right, or the community health worker, those individuals are doing tasks that the health system should be doing. They're offloading tasks that administrative often, right, that the health system should be doing. That's very easily measurable. That's monetizable. That's characterizable from a hard objective standpoint. That's one very specific example of how you can bridge the difference between, how a system feels when you interact with it and the objective value they're bringing to a system that is not covering everything it should be doing.
And you're absolutely right, because I'm taking care of my daughter, my other children. I pushed my husband to go get his colonoscopy recently, and my father has stage 4 terminal cancer.
That's right. And you are not being paid by the system, but you're doing most of its function.
Very true. I think we have time for one more very brief question.
Morning, I'm Liz Westbrook from Pecori, and I will actually, pulling on Hala's point about patient experience is evidence, I'm going to put Elliot on the spot a little bit. I know part of CMMI's work is to look at APMs or different kinds of bundled payments, all these things, and then how do you put it into the health system? And it's something Pecori is always looking at as well. So you mentioned quality measures. How are you using patient-centric or caregiver-centric, person-centric quality measures and not just the other payment incentives to determine what should move forward into the health system?
So this is like the point of the spear, right? Like the leading question for us right now. And we describe it in terms of patient-reported outcome measures. And I think getting smart, nuanced interview tools in place, getting the level of engagement where we can actually have that kind of a substantive interaction with patients. And then I'll tell you, one of the greatest challenges is then doing the same thing with a comparison group, right? So it's one thing to do it with patients who we're investing a lot into providers developing stronger relationships with those patients and trying to build those interviews off of that relationship, but then trying to identify a comparison group with who are just out there in the unimproved, healthcare system as a comparison. But it's a huge, huge priority for us. I'll say, like, our statutory mandate says we either, for a model to be successful, it either needs to save money, which gets to the equity. If we're working with people who are underserved, saving money is not necessarily really a realistic goal, or it needs to improve quality. And if we're trying to capture quality improvements in a way that we can certify a model formally as successful, we really need to quantify. And so the short answer is it's something that is a focused effort for us, and I think we'll probably, in 6 months or so, be kind of publishing where we are, and I would love for also CMI to be talking to PCORI about how we do it.
Well, thank you so much to my fellow panelists. I think we've been able to really have a deep discussion about patient journey mapping and its potential in envisioning this person-first health system transformation, and I look forward to hearing what's to come in this field. I think there's a lot of wonderful opportunities, and certainly just one tool in the toolbox, but I think we need to underline that this is a human-centered design approach that really requires that co-design to get to that person-first system. So thank you all, and thank you to our audience this morning.